I want to start this episode with a story. Imagine Sarah. She was 34 years old. She was about 11 weeks pregnant with her second baby, and she was sitting in a small consultation room at her local maternity unit. She has gone in for what she thought was a routine midwifery appointment, her first midwife appointment, the booking one. And the midwife looked at her notes, she tapped a few things into the computer, and then she said these words: "We are going to refer you to consultant team. You are classed as high risk." Sarah drove home in silence. She spent that evening searching the internet, convincing herself something was terribly wrong and something was going to happen to her or her baby. She barely slept. She did not tell her partner what she found online because she didn't want to feel silly. And here is the thing: Sarah was not unwell. Her baby was absolutely fine. She just has been labeled high risk because she was over 35 at the time of her due date. She had a raised BMI just above the threshold, and she has had a cesarean section with her first baby. Now, these are three completely common, completely manageable risk factors, but nobody has explained that to her. Nobody really sat her down to say, here is what this label means to you, and here is what is changing, and here is what it does not mean. That is what this episode is about. So, hello and welcome. This is Birth Decoded podcast by Alethea Maternity. My name is Emma. I'm a registered midwife with 18 years of experience. I have worked in the UK, the United Arab Emirates, and I've trained in Italy. And I'm also the founder of Alethea Maternity, which is a membership platform supporting pregnant women through one of the most important journeys of their lives. So really, I feel very fortunate. But today we're going to unpack one of the most anxiety-inducing phrases in maternity care. Two words that send women straight to Google at midnight, and I get it, when you're being told you are high risk. By the end of this episode, you'll know exactly what that label means, what it doesn't mean, and what questions you have every right to ask when you have your midwifery or consultant appointments. So let us start with something that might surprise you. High risk is not a diagnosis. To be entirely honest, it's just an administrative category. There is no universal clinical definition that says this exact combination, this thing and this thing and this thing equals high risk. What it actually means is that based on certain criteria that is picked up at your booking appointment or sometimes throughout your pregnancy as well, you are going to be looked after in a specific pathway. Basically, that means moving you from being midwife-led care to consultant-led care. The criteria that triggers it vary slightly between different NHS trusts, but generally speaking, they include stuff like your age, your body mass index, if you have any pre-existing conditions, like for example, if you have diabetes or raised blood pressure, your pregnancy history. So like if you had, for example, a previous cesarean section, a previous premature birth, any previous losses, and then certain findings throughout this pregnancy, like for example, if you have twins or if at any point in your pregnancy your baby is measuring small. Now, here is what I want you to really take in. Two women can both be labeled high risk and have completely different actual risk factors. One of them might have three minor factors. They will each carry a very small additional risk, but another woman might have one very significant medical condition that needs close monitoring throughout, and they will both be labeled as high risk. So the label does not tell you which women you are. I have cared for hundreds of women over my career, 1,000 possibly, and I can tell you that one of the most consistent gaps I have seen is this. Women are told the category they fit into, but not what that category actually means for them personally in practical terms. So being labeled high risk does not mean that something is going to go wrong in your pregnancy. It just means the care pathway is going to look different. So this is a really important distinction, and it's one that is almost never made clearly enough at the point when the label is first given, when you're first told that you are high risk. So now let us talk about the risk itself, because this is where things get quite interesting, I think, and frankly, where I think most women are actually let down. So when a clinician tells you that you have an increased risk of something, what does that actually mean numerically? What does that actually mean in practical terms? To be honest, I think in most cases you are not actually told that. So I think that matters enormously, because there are two ways to express risk. There is an absolute risk and there is a relative risk. And they can describe exactly the same thing while sounding completely different. So let me give you an example, because quite often it just makes a lot more sense when we're using examples. So imagine a particular complication that affects 1 in, let's say, 200 women with no additional risk factors. Now, imagine you also have a specific condition that then doubles your risk. So when someone tells you, it's like, you now have this. Doubling sounds really alarming, but doubling means that your risk has gone from 1 in 200 to now 2 in 200, which is still 1 in 100. So still 99% chances that complication will not actually happen to you. Hope that makes sense. So that is the difference between relative risk and absolute risk, because relative risk tells you the multiplier. The absolute risk tells you the actual number. And in clinical practice, relative risk is far more commonly communicated because it sounds more significant, but double the risk. If you think about it, double the risk. Twice as likely for this to happen, 3 times higher for this other thing to happen. Those phrases are technically accurate, but without the baseline, they are basically meaningless. I mean, what does that even mean? So here is something that I want you to remember and actually use in situations where you're speaking to a midwife or your consultant. Whenever a clinician asks you or tells you your risk has increased, always ask them, increase compared to what? And what does that actually mean in numbers? You are entitled to that information as part of the informed consent, and we will come back to that in a minute, because I really think it's important for you to really understand that specific context for your pregnancy and your health and that of your baby, obviously. I had a woman in my care, let's call her Nadia, who was told she had a significantly elevated risk of a particular complication in late pregnancy. She was obviously frightened. She already started planning for the worst, obviously, like you'd imagine that, the anxiety rising. When we sat down together and then I talked her through the actual numbers, she learned that the absolute risk has gone from roughly 1 in 250 to roughly 1 in 120. Still statistically uncommon, still something worth monitoring carefully, of course, but nowhere near the crisis that she has been imagining it was happening to her. So she looked at me and she said, why did nobody just say that? I did not have a good answer for her in that particular moment. But honestly, there is no good answer. It is a gap in how risk is communicated, and it's a gap that causes real unnecessary stress, anxiety, just general distress. So what actually changes when you're on a high risk pathway? Let us get practical and let us talk about all of these differences as well. Now, the most significant shift is usually where your care or how your care is being led. So, in a started pregnancy, the majority of your antenatal appointments will be with a midwife. And if everything is uncomplicated, you may give birth in a midwife led unit with a midwife, sometimes even at home, meaning that you would have seen a midwife throughout all of your pregnancy. Now, if you're on a high risk pathway, your care is typically led by an obstetrician. So, this is a doctor who specializes in pregnancy and birth. So, you'll likely have more appointments. Possibly, you'll be going to a hospital to have those appointments rather than your community center. You may have more scans. And your options for where you give birth may be more restricted. Sometimes they might advise you to give birth in a consultant-led maternity unit rather than a midwife-led unit. Now, some of those additional monitoring is obviously genuinely valuable because there are some situations where close surveillance picks up things earlier and obviously genuinely improves the outcomes for yourself and your baby. And obviously, I have seen that. I have been part of care where the extra scans, the extra checks that you would have had made a real difference. But there is also a tension that I think is actually worth naming, honestly, because actually increased monitoring does not always mean better outcomes for every individual woman on a high risk pathway. Sometimes it just creates additional anxiety, additional appointments, and all of these factors are obviously not good for you as well, because additional intervention, sometimes without the corresponding clinical benefit for that specific person, can obviously lead to all sorts of other issues. So the pathway is designed around population level risk, not specific to individual circumstances, and that is the actual reality. Look, from a quality improvement perspective, which is work that I have been deeply involved in, particularly over the last few years, maternity services are measured and held accountable for how well they risk stratify. And these are targets. There are definitely thresholds, which means that the system has a built-in incentive to sort of like classify and categorize and route these pregnancies into specific pathways. Now, I'm not saying this is wrong, don't get me wrong. In many cases, it's absolutely the right thing to do. But I think women deserve to understand that the system operates this way, and because this is the reality. And when you understand it, the conversation you have with your care team starts to make a lot more sense. So going back to this, being on a high risk pathway does not mean you have no choice or that you have to be stuck on a certain pathway. It means that conversations about choices need to happen explicitly. You can ask the questions, you can ask for explanations. In many cases, you can discuss what options are available to you, even within a higher risk framework. That's absolutely fine, and that's absolutely your right. So you should be making the most of this, which brings me back, I would say, to the part of the episode that I think matters the most, what you can actually do with all of this, because I have thrown a lot of information at you. But informed consent is a legal and ethical cornerstone of maternity care. It means that before any decision is made about your care, you should be given clear, balanced information. You should have the opportunity to ask the questions, regardless of how many there are. And you should be able to make a decision that reflects your own values, circumstances, because we're not all the same, and not just the care pathway default. So, that path where you've been put because certain risk factors. In practice, it does not always work that way, and I have to be honest. Appointments are short, clinicians are busy, and the language of risk, as we discuss it, is not always communicated in a way that genuinely enables informed decision making. It can be confusing, it can be scary. So Here are some questions that I would encourage every woman, if you're listening to this, and if you are on a high risk pathway, to ask every time you have an appointment. I think you should be asking what specifically puts me in a high risk category, and which are those factors that are most significant in your particular situation. Or you could ask, what does this mean for me in terms of actual numbers, not relative comparisons? We were talking about twice as likely, that sort of thing. What does my care pathway look like from here? And what are the reasons for each element of that? Or you could ask, what options do I have? And what are the implications of each? Or maybe you can ask, what would you recommend and why? And obviously that should be contextualized in your care, in your risk factors and your anatomy, let's say. So these questions are not confrontational, they are not difficult, they are just questions that any good clinician should be happy to answer, because they are the foundation of genuinely informed care. And obviously each one of us will want every single pregnant woman to be able to make that informed choice. And I also want to say something about the system, because I think it helps to understand the environment your care team is working in. Now, NHS maternity services operate within frameworks. They operate in specific guidelines and specific targets. Clinicians are not making decisions in a vacuum. That's why the care is very standardized across the whole country. So clinicians are working within a structure that was designed, largely well-intentioned, to keep women and babies safe, but at the population level. So when a conversation feels scripted, or when you feel like you're being steered rather than supported to make the best decision for you, it's often not because the clinician does not care, but it's because the system around them has various protocols, and protocols do not always leave room for nuance. Knowing that does not mean accepting it passively, obviously, from your point of view. It just means you can be more informed of your own care and understanding what is actually happening. You can name what you need, you can ask for time, you can bring someone with you to appointments to help you hold a conversation and ask the questions that otherwise sometimes you might just forget in the moment, and you might just leave without addressing those. Your pregnancy is yours, and your body, of course, is yours, and the system exists to support you through it, but it's not the other way around. So going back to Sarah, because I think sometimes it just makes more sense when you're looking at an example. Sarah went to her first consultant appointment armed with questions. She had written them all down. She asked what each of her risk factors actually meant in terms of numbers, in terms of her pregnancy. She asked what her care would look like and why, because I think that's the most important thing. And she asked what her choices were for the birth itself, where she was recommended to give birth. And her consultant answered every single one of them. It turned out her overall risk profile was completely manageable. Her care would involve a few extra scans throughout her pregnancy, and then a planned conversation about the birth around 36 weeks. And that was that. It wasn't dramatic as she thought it would be. So Sarah told me later that she wished someone had just talked to her like that from the beginning. Not that the label did not matter, but that it came with context, it came with information, it came with a conversation. So I think ultimately that's all that we're talking about here. And this is what I want for every woman listening to this, not to dismiss the label, not to ignore the clinical guidance, because of course all of that is very important, but to walk into every appointment knowing what you are entitled to ask and feeling confident enough to ask every single question that is not allowing you to reach to a conclusion otherwise. So here are the 3 things I want you to take away from today. 1, High risk is a care pathway category, is not a prediction. It means that your care looks different, not that something will absolutely go wrong. Second thing, when risk is communicated to you, ask for the absolute numbers, not just the relative comparison. Twice as likely, 5 times more. You are entitled to that clarity. Third thing, even on a high risk pathway, you have choices and you have rights. Ask the question, ask for time if you need extra time to process the information. Take someone with you for those appointments if it helps. So I hope you found this episode helpful. I would love you to share it with a pregnant friend or anyone who has been told those 2 words and felt like the stomach dropped, because it's not easy. I completely understand that. And if you want more of this proper, honest, evidence-informed support through your pregnancy, come and find us at Alethea Maternity. There is a membership that you can sign up to, and it gives you access to expert-led content, guides, resources that are designed around what women in the UK actually experience. So if you want all of this, you can find us at www.alethea.co.uk. So thank you so much for listening. Take care of yourselves, and I will see you in the next episode.